through the process of the PhD and of the study. So the overview of the presentation, I'll give you a bit of background and summary of the literature, research questions that guided the study, the theoretical framework that guided the first half of the mixed methods study of the methodology, which I'll go over, the results, there's a discussion of the findings and limitations of the study, implications of the findings for healthcare policymakers and nurses, and a conclusion. So to begin with, one of my interests was the fact that nurses were found to be the sickest workers among all occupations. And so for me, that was stunning. I teach nursing, and why is it that healthcare providers are the sickest workers across Canada? And then the significant cost to the healthcare system, over $711 million. So that's related to illness, disability, injury, and absenteeism, just of the nurses. And so research suggested that nurses' health was linked to the quality of their work-life environment and unhealthy environments. And as we know, nurses have a prominent role in the healthcare system in Canada and in our province for sure. And nurses, along with other healthcare providers, facilitate the holistic healing processes for clients. And just to define what a nurse healer is one who facilitates another person's growth toward wholeness or assists another with recovery from illness or transition to a peaceful death. Healing is not just curing of symptoms. And so what I did as well with the literature, you'll see on this table that there were some factors identified that negatively impact the quality of nurses' work life to urban and rural nurses. So just for example, increased or unpredictable workloads, inadequate resources, lack of equipment, lack of diagnostic services, lack of organizational supports. There's a need for continuing education, also work-life home balance. And then there were some additional factors found for nurses specifically working in rural and remote locations. So they were found to be needing a broad generalist knowledge base. The catchphrase is called jack of all trades. So they don't know who they're going to get into their department, and so they have to have a really wide knowledge base for their practice. Excuse me, feelings of professional isolation in some locations, application of new e-technologies all the time to upgrade their information, but also for using with patients. Transporting of patients from rural locations is a huge impact on the quality of their work life. And then when I'm looking at statistics just for Ontario, 7.3% of Ontario nurses work in the rural and remote areas. And a large amount, 42%, are around 55 years of age who will be likely retiring within the next 5 years. So that has an urgency about it to address any quality work-life issues that could impact the retention and recruitment of nurses in these areas. And when I did my study, reviewed the literature, there was only one study that actually had looked at the quality of nurses' work life in Northeastern Ontario. So that's how I developed my research questions, which were how do RNs and nurse leaders evaluate the quality of work life in Northeastern Ontario and rural and remote hospitals, and in medical surgical practice areas in large and small Northeastern Ontario urban hospitals. And I separated that out because in larger centres or larger hospitals, they do actually have units separated into medical surgical areas, whereas in a smaller rural and remote, it's all one hospital. There's no really different designations. I also want to look at what factors, quality work life and nurse practice environment factors were associated with nurses' stress, and if there were similarities or differences of how RNs from each of the geographical locations evaluated their quality work life. So the nursing work-life model is a model that was developed by Lecce and Lassinger that identified 5 different categories where there's a lot of variables impacting nurses' work life: leadership, resources, collegial relationships, participation, foundations for quality. And you can adapt to the outcomes. So I was looking at quality, work life, and stress. So that this model helped me zero in on some of the factors to be examining. The model wasn't there to test any theories or to move forward that way. Also, I defined urban, rural, and remote using the Statistics Canada definition of rural and small town. So that uses census metropolitan area, which is at least of 100,000 people or more of a population, and census agglomeration, which has a core population of 10,000 people or more. So that's all considered urban population. Everything else is considered rural. Remote is considered where there's not year-round access, road access, or that people have to rely on airplanes or trains for transportations. So to move on to the methods section, I used a mixed method sequential explanatory design, which is a mouthful, but it has two phases. In the research phase one, it includes collecting quantitative data, so that's the survey data that I collected. And then phase two is the qualitative interview stage that I did with some of the participants to help explain the findings from phase one. So the setting was in Northeastern Ontario, which people here would be familiar with. And I had 4 hospital locations, one large, one small urban area, one rural, and one remote. And they were selected based on willingness to participate. I think I approached about 8 different hospitals, and 4 actually agreed to be put on board. And I also used a convenient sample for the nurses to get my sample, or to get my participants. So the data collection used a questionnaire, which was actually quite lengthy, 13 pages, and it had demographic questions plus 3 different scales, specifically looking at the quality of work life, practice environment, and nursing stress scales. And you'll see some crump alpha that mentioned that the tools were reliable. So for sample selection for phase 2, during phase 1, I included a little checkbox asking people if they wanted me, if they could consent, allowing me to contact them to ask them if they wanted to participate in the interviews. So that's how I did that. And it's very important to get the insider perspective of nurses who are actually working there and the nurse leaders in the area to help expand the findings. Okay. So the data collection, again, for phase 2 was interviews. It lasted, some of them were 32 minutes to 1.5 hours. They were audio taped, transcribed, and then inserted into a software program called NVivo for analysis. I forgot to mention the qualitative data analysis. I used SAS, which is a software tool for computers, to help generate the statistical analysis, and I used frequencies, percentages, also multiple, and the logistic regression were conducted on that. So from the qualitative interviews and into the what I call the murky fog or the abyss, and then you need a guide. So I used Interpretive Descriptive by Sally Thorne as a guide to help me look through the qualitative data to make sense of the shared realities of what nurses were saying. So it's an iterative process and it's time consuming, but in the end, very worthwhile. So as we're moving towards the result phase. So altogether, the sample, I sent out 319 surveys across Northeastern Ontario to these 4 hospitals to the nurses. And I received back 173 surveys, which was a good 54% response rate for a male survey is really good. But the majority of participants were from the urban areas and small urban areas. Fewer were from the rural and remote locations. Plus, I also invited participants to add comments on the paper. So there was room for that. So that was analyzed as well in a qualitative context analysis and included with the phase 2 data. And then I had 47 nurses that agreed to be contacted, but actually 17 nurses and nurse leaders at the end agreed to be interviewed for the qualitative phase 2. And this table shows you just a summary of the demographic information of the RNs. The majority of RNs were female, aged 20 to 29, which is a younger population. They were married, had a baccalaureate degree, were working full-time as staff nurses, and earned a salary between $70,000 to $80,000 before taxes. Now, interestingly, almost 87% were able to take their scheduled days off. However, when you're looking at how can they take the regular scheduled breaks while at work, 51.4% stated they couldn't take their regularly scheduled breaks. Plus, they had overtime that they worked at 82.7%, but they were paid according to 72.8% for the overtime that they put in. Now, when I took the quantitative data from phase 1 and did the multiple regression, logistic regression analysis looking at key factors, exhaustion, adequate support services allowing nurses to spend time with patients, supervisory staff that are supportive, and enough staff to get the work done were associated with both the quality work life and with the stress. So those were key factors going into the qualitative to figure out what was going on that was creating that. So as I'm entering into the analysis more, the fog is lifting, and then you come to what Sally Thorne refers to as the overarching theme. So supporting holistic healing and nurse healers was the culmination of the themes and data that came out from this study. And then they're supported by different themes, which I'll go through individually here. So when you're looking at the center is the holistic healing of clients, that would be theme 1. But surrounding that, I have individual nurse characteristics, okay? So several authors have indicated that individual factors such as age, gender, education, work-life experiences affect nurses' perceptions of the quality of work life and their work environment. And so even though it's in between theme 1 and theme 2, it's actually pervasive in all of the themes. Like you can't remove that from all of it. So, but in order to depict it, that's how I put it in there, okay? So it intermingles with all of these factors. So then I'm going to show you for holistic healing of clients, the overall theme 1. This is an excerpt from nurses that, I don't know if you guys want to read it or I'll read a bit of it. So urban nurses talking about we get the sickest of the sick. There are many competing demands, and it shows how their time is split. How can they manage and prioritize the patient care, and that they don't feel that they can provide the physical tasks, let alone the emotional or psychological needs, which they also feel is a priority. And the nurses have difficulty reconciling the cost effectiveness and cost efficiencies of the different ideologies within the healthcare system and within nursing. This second theme, facilitating healing at the bedside, includes 5 different sub-themes, and these describe the supports shared by nurses as needing to be there for nurses to provide quality, holistic patient care, congruent with their professional standards, so that's enough time and resources to do the job, therapeutic relations with their colleagues, supports for professional growth opportunities, nurses' voices at the decision and policymaking tables, and supportive leaders who listen, were all shared. So this is an example of this sub-theme for enough resources and time to do the job from a rural and remote nurse. They don't have CT scanners, so they have to rely on orange air ambulance to transport patients, and that causes a ripple effect. If there's delays with transporting patients out because of their condition could deteriorate, or when they get to the hospital, they get stuck with weather, and 36 hours later, the nurse is still there, so they're already short-staffed, and the nurse is stuck in another hospital. So those are some of the issues that they were talking about with having enough resources. And also about the budget was a huge concern for nurses and nurse leaders. The budget and funding restrictions also impacted continuing educational opportunities for other nurses. And it is something that's absolutely needed for our profession to continue. Also, they talked about morale. So relationships with other colleagues can become strained to horizontal violence, especially when you're physically tired or emotionally tired. Nurses start eating their young. So you see older nurses start taking it out on the younger ones. So all of this is a ripple effect that you see. Okay, so this theme 3 is the geographical hindrances to healing, healthcare system inequalities. And this describes the geographical differences and unequal access to resources, healthcare services, and supports for northern, rural, and remote populations, as well as nurses and allied healthcare professionals that are necessary for healing. And when we're talking about inequalities, we need to define it because they can be used interchangeably with that and health disparities. Okay, so health inequality is defined as the differences found between the health status of different population groups, such as those living in urban, rural, and remote locations. So when I'm talking about the geographical differences, here's an excerpt that kind of describes what nurses are talking about there, how they get patients in really bad conditions who have waited so long up north or haven't had access to proper treatments or healthcare professionals, and they come to the larger urban centers quite ill and critically ill. This is another about the geographical differences. Everything is transferred out. So nurse leaders and nurses talked about the type of accesses that were required. So CAT scans are usually not available in the smaller urban locations or rural or remote. So it all takes time for the treatment to move people in and out of these locations. And theme 4 is supporting healing beyond the hospital bedside. So this talks about the healthcare system inequities in policies, funding, and decision making. So it conveys the accounts of how the governmental healthcare system policies, the legislation, funding decision-making processes outside of hospitals within the larger regional areas impact the nurse's ability to care holistically for patients at the bedside. And I've defined health inequities as the differences in health status among groups that are deemed to be unfair, unjust, or preventable, as well as socially produced and systematic in the distribution across the population. And us living here in Northern Ontario really see this firsthand of how differences in the resources are between northern and southern parts of our own province. And again, with different populations as well. So here's an excerpt to kind of show an example of what was talking there. We probably won't get funding per se, but if we had access to the resources or even community, when you look at community, some of our community partners just cut services because they don't have the money, so they don't go into deficit. So then they're talking about the lack of the ripple effect of what happens when there's no funding and patients have to come back to the hospital, which impacts their budgets and all. It just seems to be a vicious circle, eh? And so nurses and nurse leaders shared the need for equitable funding formulas, policies, and performance measures that determine the allocation of resources, consider the unique needs of each community, that would actually address the health challenges that are unique to each community, and support healing processes for northern, rural, and remote populations versus the one-size-fits-all type of situation. So they talked also to me about the performance-based funding models, benchmarking targets, and the funding freezes, and the LIN targets described as being applied equally across hospitals, regardless of the geographic location. And a nurse leader said, I can understand the concept regarding the quality-based procedures and access. It works well if you have the resources. So again, they're not really opposed to some of the strategies that are being used, but it's this one-size-fits-all that you really need to look at and apply fairly, right? And then the nurse leaders talked about the impact of what they had to do to justify any of the funds that they got. Several reports that they have to write, and if they don't meet the targets, they don't get the funding. And so again, it's another rock and hard place situation. So nurse leaders are under huge fiscal pressures to do more with less funds, and that's what they're experiencing. So when nurses say we need more staff, well, there's no money. How can you fight that when there is actually no money to give, right? So then again, I'm looking at the holistic part of these themes here and how it impacts nurses' health outcomes. So all of these themes come together to help explain that. Majority of nurses across all sites describe not having enough nurses and non-nursing staff, having heavy workloads, not enough time to provide quality holistic care, the inability to take their scheduled breaks, lack of supports and resources. All of this was linked to their decreased quality of work life, increased stress, and exhaustion. Okay. And this excerpt is from a nurse working in rural and remote locations where there were a lot of work-life balance issues that affect, I think, that every facility and every RN that are present here. Short staffing, increased patient load, issues around inadequate training, education, all these contribute to stress and difficulty. There's isolation, transportation issues, getting in and out. 4 months of the year, you can only get off the island by helicopter, which is a challenge. So there's all sorts of different issues that impact nurses. Talking about patient transportation, again, difficult if there's delays. So nurses shared about the geographic location, and again, inadequate staffing, increasing the workload, the need for training. And other nurses discussing about the heavy workload and physical, emotional tiredness that they have. Some days you want to go home and cry. You're tired. If it's one of those days where you have a 24-year-old pass away and you're dealing with 4 or 6 other very, very ill patients, some days you want to cry. So it's a very emotional type of situation that nurses go through. And so they were asked as well, what do you need from admin? What would help improve your quality of work life? So some of those suggestions were described was just to listen to nurses' concerns, be receptive, be supportive, respectful, empathetic, compassionate, even if you can't fix it. Just know that you're listening to us. Our voices are being heard. Okay. So then getting closer now to the discussion part for the findings. Sorry, go back. Okay. So then leading into discussion, the majority of participants were from the large and small urban locations. So the response rates was lower in the rural and remote locations. So in future, I would probably use follow-up reminders, postcards, or email communications built into the project to try to booster that type of participation. The inability for nurses to provide quality holistic care with potential negative effects on the healing process of patients was described by the nurses and nurse leaders, and that's consistent with the literature by several researchers who have suggested that nurses' quality nurses' work life impacts patient outcome, and nurses' concerns were also related to the quality of patient care linked with heavy workloads, and again, that was also found in the literature. Heavy workloads with short staffing actually were linked to increased falls of patients and medication errors. So it leads to negative health outcomes for patients. Increased staffing or an appropriate amount of staffing and resources were also associated with fewer patient staff. So again, there's evidence there that supports the need for more staffing. Tensions arose for nurses between conflicting ideologies. On one hand, that nurses needed resources and supports to provide holistic care, but on the other hand, they're not opposed to accountability and fiscally responsible healthcare system. So they recognize that they need standardization of the performance indicators, and fiscal accountability are important for the quality of healthcare. So in all hospitals in Northeastern Ontario, they've been applying lean approaches. I'm not sure if people are familiar with lean, but it's actually, I think, from Toyota, which is a consumer-based business corporation that looks at what the customer values and looks at reducing ineffective practices that supposedly saves money, right? However, evidence is lacking that supports the quality improvement of cost reduction claims from the lean methods. And my time is getting short, so I'm going to try to speed up here. So also, nurses identified several difficulties with meeting targets for balancing the budget, and targets were perceived as unrealistic for Northeastern Ontario. And this was also found in the literature reported by LINS that the provision of cost-effective health services is challenging for the limbs to do. Okay. Differences in the types of work and tasks between urban, rural, remote nurses were supported in the literature, especially about transporting patients to larger centers, and also the stress related to a lack of access of resources when they're not readily available. So there are also a variety of factors that contribute to health inequities that include discrimination, discriminatory policies toward Indigenous and Francophone people, as well as other factors associated with the social determinants of health and geographical location of some of these communities. But at the same time, there have been concerted efforts to address the health inequities that include, for example, teletechnologies, telemedicine, different recruitment initiatives, mobile health clinics. Okay. Healthcare decisions applied to northern areas continue to be made in urban centers, and solutions have to be found in our location, according to Jennifer Walker. They can't be imported. We have to look at our unique situation. They talked about funding, allocation of resources again, and those have to be looked at as well to be more specific in our area. The role of nurses has been shifting away from the provision of quality holistic primary care models towards more of a functional task-oriented model of care, more cost effectiveness, cost efficiency. So there's a new vision rooted in nursing values of holism and restoring the centrality of the nurse-person relationship, such as strengths-based nursing that has the potential to improve the healthcare system. It also places patients at the center of the healthcare system need to be met and achieve high-quality patient care that is cost-effective. I'm just going to scoot down to some of the limitations here of the study. It was cross-sectional, limited to the ability to identify causational factors, and there's some selection bias when you don't use a random sampling strategy. So it was convenient sampling. And there were time lapse between the data being collected and analyzed. So there could be some changes that have occurred at each of these sites or improvements for the participants. However, the literature to date still suggests that there are factors impacting nurses' quality of work life and stress related to some of the issues that were identified in this study. So I'm going to briefly talk a few more implications before wrapping up. So for healthcare policy and decision makers, resolving health inequities and inequalities facing the healthcare system across Northeastern Ontario requires a concerted effort by many people to effect changes to implement actions through policies. Solutions have to be found in the North by the North, and hopefully not a one-size-all-fits-all solution with funding models as well to be changed and improved upon. Performance measures that each hospital across the North have to address with their reports also needs to consider the existing community supports and resources in each of these locations and to see if they actually address the healthcare needs of the patients and the healthcare providers. You have to be engaged with community stakeholders to find out and determine what is actually needed. There's a gap in exploring policies and evaluating interventions and policies specific to nurses within each of the geographic locations. So future research could evaluate the effectiveness of these programs. And also related to research is community-based participatory action research could be utilized to help expand identifying the unique needs of communities. Oops, in conclusion. Yeah, okay. The findings of the study highlight the importance of addressing several factors associated with Northeastern Ontario nurses' quality of work life and stress. Supporting the holistic healing of clients required changes to inequitable healthcare system policies and decision-making processes that perpetuate healthcare system inequalities. Geographical hindrances to healing processes and inequalities impacting nurses' quality of work life, stress, and health underscored the supports and resources required by nurses. Nurses must be able to work in environments that allow them to maintain their legal and ethical standards when providing holistic care to facilitate the healing processes for patients. And changes to improve the nurses' quality of work life will require a concerted effort again by several people and agencies with willingness to listen to the local concerns. And improving the quality of work life and reducing their stress can positively influence the health outcomes for nurses, patients, and the long-term sustainability of the healthcare system. Maintaining the status quo is unacceptable and contributes to ongoing injustices experienced by populations and healthcare providers living and working in Northeastern Ontario. It's imperative that all stakeholders, including government, healthcare professionals, regulatory bodies, nursing unions and associations, and universities work together in collaboration to eventually actualize the vision of the delivery of a high-quality healthcare services that are equal and equitable to all Ontarians, regardless of their geographical location. And thank you. All right, so if there's some questions, you have anybody here? Anybody?
Yeah, so for those of you who are online, you should hopefully be able to hear me, but you are able to type in a question if you have one for Judith, and I can relay it to her. And is there a question from anybody here? So, Nancy, if you speak loudly enough, this will pick you up, and everyone online can hear your question.
Okay, that was very illuminating. Thank you. It's also very depressing. And when we look at impact of work conditions on our nurses, we try to think about applying basic health and safety principles, like, you know, the internal responsibility system and the hierarchy of controls to fix things. But I can't help but think all of anything we could do would be dancing around the edges of the solution. Is more staff, isn't it?
Partly.
Okay, that's what I need to hear.
Okay, so I'm gonna have to block you out here. Can I move this down further, Kevin? Can I lift this down? I can see.
Oh, I could.
No. That's good. I got it. No, that's good. So the impact is multifaceted. So just increasing the staff doesn't necessarily mean that's going to alleviate some of the issues. It will short term, but there's a lot more that's needed, such as policies where nurses have decision-making abilities over that funding, proper funding for the services, resources that are needed, especially when you're out in the rural and remote, small urban locations, such as transporting the patients. Staffing would help alleviate that. But they also need to have perhaps mobile clinics that can go up to the north or to the rural locations, or some of these diagnostic equipment that would reduce some of that. So it's multifaceted. Increasing staffing is definitely going to be welcome, but it's not the only response.
Okay, thanks. Points well taken.
Nick has one too.
I'm not sure if I saw this right, but with your sample, what was the age range? 20 to
The majority of them were between 20 to 29 years.
Why do you think it was so young?
There's a high retention and recruitment issues within the nursing profession, mainly due to a large burnout and stress level. So the younger ones have been coming in and they're there, but there's a wide gap of switching over that way. Okay. Yeah, I was surprised to see that many, but that also adds to whether or not, because you're younger and you have proper mentoring, and if you don't have enough years experience, that's also a factor that adds to your stress, because a lot of them don't have mentoring capabilities as well. So that's another thing. If you have increased staff, but if it's young staff with inexperienced, you're still going to have stressors. So you have to have a balance between those that are still us old ones, or at least it used to be 5 years to be an expert in an area, right? But people are switching over a lot. So you get people who are 2 years in a role might be emerge as the senior nurse. Same with the rural and remote. Like 2 years, you're in charge of the hospital at night.
So the nurse leaders are fairly young too, then.
No, nurse leaders or administrators.
Okay.
Who were nurses that longer in the
Okay.
field, not necessarily young. And
So yeah, you listed many factors that contribute to uh, reducing quality work life in nurses. I was surprised to see shift work not be mentioned. Just thinking about, obviously there's the budget, there's the emotional attachment, there's the physical exhaustion from the workload, but even just like at the root point, like many occupations with shift work and um, like just longer shifts and working overnight. I think a lot of those occupations already have a reduced quality work life. Like even at your baseline, no matter how good you are at work, you're gonna have a hard time. Did anything come out of that with shift work? Or their shift rotation, I should say?
Actually, I did ask information on that, and I collected data, but it wasn't something that came up in the qualitative interviews. That it wasn't really identified. Exhaustion was identified, but it wasn't linked
With their shift.
the night. You're correct. The literature is right that there is impact on nurses' health and the perceptions with working night shift and the shift rotation. So there's a lot. That's a whole other study
Yeah.
that I wasn't able to. There was too much in here as it was to try to do that. But yeah, there's differences like the nurses who work 12-hour shifts. They love the 12-hour shifts because they don't have to be away from home so long. And then there are other nurses that like night shifts. They do that all the time. So it varies. I would like to see actually more research done on that and to implement maybe a 10-hour shift and see how that rotation would work. And would still not burn them out and still maybe be a compromise. I don't know if that's been done, but I think in Europe there was a conference I was at that I would like to look at, a 10-hour shift, but you have to get the unions involved and on board with that. Yeah.
So I know you had alluded to it that there's been some time since you collected the data, and sometimes things change quickly, especially in political landscape over the last few years, and even in Ontario, for example, we have an upcoming election. So I wonder if you could comment then on where is your sense of in what direction are we trending with regard to some of your findings? Is it getting worse? Are there some aspects that are getting worse, or some are getting better? Or maybe if you have one that's really a cause for concern and one that you're saying if we could do more of this, that's a light at the end of the tunnel.
I think generally overall, that's a great question, and boy, I'd like to put you on the spot.
Yeah.
This was only my own personal
view of
it, but looking at the landscape of healthcare within the province, it's huge cost to the province. It is, and whenever there's cuts, it's always to staff. So what I'm finding interesting now, just with our local hospital here at Health Science North, they've just announced a huge deficit. So I'm looking to see how is that going to impact the number of nurses at the bedside. Will there be additional cuts? Usually there is. There's usually cuts to education and to nurses because nurses are the most expensive part of the budget. So I don't know what's going to happen with that. I do know though federally there was a lot more funding put in for rural and remote locations, so that's positive. Retention recruitment issues, there's task force working on that, so that's positive. I think what I would like to see, and my hope is to be able to expand on this research and start doing some programs in rural and remote locations with nurses, like continuing education, to evaluate them, to see if that helps improve the quality of their work. So I think we still haven't done a lot in evaluation of any of the programs or interventions that are out there that haven't been done, haven't been tried yet, or we need to evaluate that. But I don't know where the landscape's going to fall. I really don't.
I do have one other question, just a quick one. I know qualitatively through your interviews, it seemed like the theme came out that there's obviously more challenges for nurses in the rural or remote areas. So you think that's where your attention would want to spend, maybe to try to target those. But through your scales, like your quality work life scale that you used and on your surveys, did they also report worse quality work life, like for the rural and remote compared to urban?
I didn't. the way the analysis came out, it didn't really specify.
Okay.
There wasn't a
Yeah,
large
you had
enough
it. You had
population
yeah.
to be able to find out logistic or multiple regressions for that specific population. I'd need more. Qualitatively, yes, there was a lot more, and it was almost one of the slides I was trying to create was an arrow of red where the stress gets larger as you're further away
Oh,
from
yeah.
the urban setting. And that's what's really came through on the qualitative interviews with the small urban rural remote was the amount of transportation, the amount of critical care that's needed, and your knowledge that base you need to take care, and how stressful it is when you can't get a patient.
Yeah, for sure.
So a question from online that I'll read because not everyone else here can just see it. But so they thank you for sharing your findings, and they found it very, very interesting. Question is, can you elaborate on nurses reporting issues with their immediate supervisors or with their employer? Are these concerns brought forward, do you feel, or do you think they keep these barriers and emotions to themselves? So, and if reported, is it done verbally, or is there a paper trail for employers to be able to track trends and corrective actions for these types of issues? So any thoughts there to share on reporting, around reporting?
I can only share from the nurses that spoke to me about that. But I can't generalize that to, I don't know what is done in each specific hospital site as to whether or not they have a process to address issues. Most of them do. They have practice councils, um, practice leadership councils where they can report things. They have staff meetings. They do. Their leadership varied from each location. It depended on the nurse if they had a good relationship with their nurse leaders or the program managers or administrators. That varied depending on how they were perceived, if they were being supported or listened or things like that. So it's really difficult to answer, but there are, majority did find that their supervisors were supportive and were listening, but there was just no money. So they would move it up, and how can they address it? Because they were also under the same gun, the nurse leaders, of having to balance the budget and target and write all these reports if they didn't get it. So there was no money. So the nurses recognized that. So again, it depended on the relationship they had and with what the issue was. I hope that answers your question.
We'll wait if there's a follow-up that comes in online. But another question is around, you mentioned the concept of nurses eating their young, which is a very familiar saying, probably all too familiar. But was there any indication given of the dynamics between nurses and other healthcare practitioners or other health professionals across the different settings? So, if you think of larger urban centers in healthcare facilities, you'll see quite a breadth of healthcare professionals from, experts and surgeons down through physios, etc. But in smaller, more urban places, it may only, or more rural places, sorry, there may be fewer of them. So did that dynamic come up? You can comment on that? Yeah.
The rural and remote nurses worked more of an interdisciplinary type of team. They could rely on each other, especially in the remote areas. There was quite a good collegiality because people were kind of stuck in the same community too. So you got along, right? And but in the other areas, again, it depended on the personalities of different people. And in the rural areas, some nurses talked about the fact that there's a lot of locums where physicians come and go, so there was an inconsistency. So you're going to get conflicts because people who are coming in on locums may not understand that in the small urban and rural location, you can't just pick up the phone and say, okay, get this CAT scan done. You've got to first, make arrangements in ambulances. You've got to do all of this critical care calls and contact another doctor in the other facility to accept a patient. So there were some of those conflicts that went on. Nurse to nurse horizontal violence, we know, stems from a lack of resources as well, and so they start attacking each other. It's reality, and we see that in different locations as well, where people not doing their part of the workload or perceived not to be doing their equal share, then that's going to create some conflict. Nancy? Yeah?
Oh, just a side comment. I mean, we always hear nurses eat their young, but in health and safety studies of stressed environments across the board now, we're seeing people eating each other because
Yes.
of the stresses.
Yeah,
So
absolutely.
it's not just nurses anymore.
Okay, not good to hear that, but good